So evaluation of the acutely suicidal patient. This is going to be truly your bread and butter in this case. As a psychiatrist, you want to do a proper evaluation of anybody who comes in and says, I'm voicing suicidal ideations, I have thoughts of hurting myself, and whose actions might suggest suicidal intention, including some patients engaged in risky activities. So some patients, say bipolar disorder, where they're very impulsive, they're very they're in a manic episode, they may be engaging in behaviors that could really harm themselves, and you got to assess, is this with the intent to die, or is this just simply part of the pathology of the illness itself? You don't know. You need to figure it out. So again, evaluation is extremely important. It's important to remember that asking about suicide does not increase the risk of suicide. Again, contrary to popular belief, if you ask people about suicide or you bring it up, or even if you ask about methods, that's also important too. If you say, have you thought about cutting yourself, taking an overdose of pills, stabbing yourself with a knife, a gunshot wound, anything, people think that would make people more suicidal or might put thoughts in their heads, but contrary to popular belief, it's actually protective to talk about it. And a lot of patients are very relieved when they have the opportunity to think it through and talk about it. You want to identify any acute, short, and long-term risk for suicide and determine ways to diminish each of those things. That's also an important part of the assessment. So again, identification of risk factors, and we talked about that many times already. You also want to look at the stress diaphysis model, is commonly applied to understanding suicide risk. So this model considers acute precipitants, the stress, in the context of underlying vulnerabilities for suicide. So again, stressors, a lot of times stressors are interpersonal relationships, financial difficulties, medical illness, chronic mental illness, homeless, being homeless, etc. All of these things are considered stressors. And it's best to begin any of these assessments with general questions. Do you ever feel like it's not worth living? And then build some rapport with the patient before asking the more pointed questions. So you can start with the more open-ended questions, and you don't have to necessarily just come right out, do you want to kill yourself? Because that may turn some of the patients off, that may stop them from discussing with you more honestly and truthfully what's really going on. So start with the open-ended questions, start with some basic stuff. Ask about, when you're doing this evaluation, you really want to ask about, just like you would any other medical illness, the intensity. And the way I ask about the intensity is like I want to know how far you've gotten, how much you've done, how much planning has gone into whatever thought, suicidal plan that you've had or thought that you've had. And I want to know how disturbing it is to you every day. Is it interfering with your ability to work? Is it interfering with your ability to take care of your children? Is it causing you, a great deal of stress, inability to sleep, etc.? So that all kind of plays into the intensity. The frequency, I like to ask about this by saying, over the past week, how many times have you thought about ending your own life? Now, if they say I thought once about it, or it's like twice during the last week, that may not be as bad. But if someone's saying I'm thinking about ending my life every single day, every hour of every day, now I'm a little more concerned at that point. And I'm going to take everything they say very seriously, regardless. I mean, even if you've only thought about it once. But again, frequency helps us to determine severity and duration of these thoughts. How long are they going on for? And of course, you want to screen for any kind of plan. You want to say, okay, so you've thought about ending your life. What kind of thoughts have you actually had? And then if they say, well, I thought about taking an overdose of medication. Great. Okay, we have the plan. You thought about taking an overdose of medication. How far did you get with the plan? Did you gather up all of your pills? Did you put them out? Did you have them in your hand? How close did you get to actually doing something? And how far did you get in the planning process? Or was it more of the situation that you hear a lot too, is, well, I was researching methods on the internet. That's also very, very popular among people. They'll say, well, I was looking on the internet at different ways that I could end my life. So this allows you to, again, assess lethality, because lethality is one of the most important things, and we had already said in previous videos that gunshot wounds are the most common means of completed suicide, and that they are also the most lethal means. Access to firearms should be explicitly asked. I always ask about access to firearms regardless of what the person's presenting with, even if they're not suicidal. Because again, a lot of psychiatric disorders involve impulsiveness, and if you're impulsive and you're disinhibited, you may be more likely to hurt yourself. Maybe not intentionally, but just because you're not thinking clearly, you're not thinking logically. So access to firearms is really, really important. Ask about it. It's a common method of suicide in men and women, and it accounts for nearly 60% of all suicides. So very, very important. Also, collateral information. Anytime someone comes in and says they're suicidal, talk to a family member, talk to a friend and other providers. Figure out, what's going on here. Who have they communicated with? Who have they told about these thoughts? Have they verbalized any kind of plan to those people? And is it anything different or contrary to what you already have? So that's another important point. So in the evaluation suicidality during the initial interview, you have two goals, basically. So there's two overriding goals that you want to try to accomplish whenever you're evaluating a suicidal patient. And the first one is to determine if there's any immediate risk for suicide. The second goal is to determine the current or past suicidality. So kind of what I've already said. You want to explore what the current situation is with the suicidal thoughts or attempts, etc. What's going on right now. And you want to determine, have they ever done anything in the past to hurt themselves? And before asking specific questions, you want to familiarize yourself with the risk factors. So in order to familiarize yourself with the risk factors, you may want to use the mnemonic SAD persons. It works pretty well, and I will go over that here. So SAD persons. So S is for sex, and again, we know women are more likely to attempt, men are more likely to complete. Age, so there's actually a bimodal distribution, with teenagers and elderly being at the highest risk. And I said a lot of the suicides actually occur in people over the age of 60, and the other at-risk population that I mentioned in previous videos was the teenagers, or adolescents from age, say, 15 to 24. Depression is another risk factor. Obviously, I said 90% of patients who complete suicide have at least one psychiatric diagnosis. So 15% of depressed patients die by suicide. Previous attempts, I had said previously in many videos that future behavior is best predicted by past behavior. So you want to take a look at any previous suicide attempts. 10% of those who previously attempted die by suicide. E is for ethanol or alcohol. So 15% of alcoholics complete suicide. You want to, again, think about alcohol. It's disinhibiting. It causes people to act impulsively. Long-term substance use disorder, 9 years plus, leads to more likely attempts at ending your own life. This is all kind of contributing to suicidal thoughts and behaviors. Loss of rational thinking. So this is the one case where psychosis kind of plays the role. Loss of rational thinking, again, psychosis, it's a risk factor. We said previously 10% of schizophrenics die by suicide, not as many as you might have previously thought. Social support is lacking. That's what the S stands for in SAD persons. Again, social support is really, really important. Feeling like you have people who give a crap about you around you is a big deal. And being able to rely on those people to help you in your time of need or time of crisis is really extremely important. Organized plan. O stands for organized plan. So do you have a well-formulated plan? Have you come up with all the details, and did you have it all laid out and ready to go? N is for no spouse. So obviously being divorced, separated, widowed, or having children under the age of 18 is protective. Okay, so the other point I'm making there is that, again, having children under the age of 18 is protective. It's actually probably the most protective factor you can screen for, is having children under the age of 18. And of course, S is for sickness, so chronic medical illness, as I've mentioned in previous videos, is an extremely important screening or risk factor for suicide. Evaluation of acutely suicidal patients. So SAD persons works well, and this is an important distinction actually. So SAD persons works well for assessing the long-term risk of suicide. It's actually way less useful for determining immediate risk. So SAD persons, again, assessing long-term risk of suicide, it's not as useful for immediate risk. And to be honest with you, there's not much research out there in the area of immediate risk factors for suicide. However, if you look, there's a few short-term warning signs for suicidal behavior that the American Association of Suicidology actually supports. So the ones that the American Association of Suicidology support are rage, so severe anger, reckless behavior, feeling trapped, increased substance use and social withdrawal, anxiety or agitation, insomnia, hypersomnia, mood changes, and lack of purpose for living. So it's a lot of different things, and the problem with this, I think, is that it's very non-specific. I mean, people have rage for a lot of different reasons. People engage in reckless behavior for a lot of different reasons. People feel trapped or have increased substance use or socially withdrawn. I mean, all of these things really can be seen in multiple different psychiatric disorders, and not every single person who has these things ends up attempting to take their own lives. So, point being is, area of open research is going to be immediate risk factors for suicidal behavior. It's going to be an extremely important thing in the future. So I'm going to stop there for now. I'll pick it up in the next video, and we'll talk a little bit more about different methods of assessing suicidal patients.